Good evening in the USA. I'm Dr. Xiaoxiang Chen, executive member of the USCACA and also chief development officer of Harbour BioMed. I'm so glad to host the China-US Anti-Cancer Symposium today, organized by CACA, USCACA, co-organized by Helan Cancer Hospital and the China Earth, and sponsored by Tianjin Company. First, let me welcome Secretary General of China Anti-Cancer Association, Dr. Ying Wang, to make opening speech. Dr. Wang, please.
Thank you, Dr. Chen. Dear distinguished guests, ladies and gentlemen, good morning. My name is Ying Wang, General Secretary of China Anti-Cancer Association. On behalf of the organizers, welcome all of you to participate in 2021 China-US Anti-Cancer Symposium. In recent years, the 5-year survival rate of cancer patients has improved steadily through improvement and the promotion of early screening, strict control of risk factors such as smoking, health style, etc., and the breakthrough progress in treatment of surgery, radiotherapy, chemotherapy, target therapy, and immunotherapy. In addition, a total of 29 new cancer drugs were approved worldwide in 2020, mainly in US and China. The two nations have now become the global benchmark in the field of cancer research and innovation. In this conference, we have invited some of famous oncologists from China and the US to give presentations. They are Professor David Tuveson, President of American Association for Cancer Research, Professor Everett Vokes, President of American Society of Clinical Oncology, Professor Jihui, President of Tianjin Medical University Cancer Hospital, Professor Jiuwei, Director of Department of Oncology, First Hospital of Jilin University, Professor Zhao Fanghui, the Head of Department of Epidemiology, Cancer Hospital of Chinese Academy of Medical Sciences, Professor Cai Tongyu from Sun Yat-sen University Cancer Center, Professor Gao Tianhui, the Deputy Director of the Department of Oncology, Henan Provincial People's Hospital, Dr. Yan Li, the board member of USCACA, Dr. Chen Xiaoxiang, the executive board member of USCACA. They will discuss basic research and the clinical progress of cancer, comprehensively review the latest research results and existing challenges. I believe that this international symposium will offer us a good opportunity to share the latest research results, strengthening academic exchanges between China and the US, and facilitate cooperations to advance standardized diagnosis and treatment of cancer. Finally, I wish the symposium a full success and hope everyone will be safe and healthy. Merry Christmas and Happy New Year in advance. Thank you.
Many thanks for Dr. Wang's opening speech. Let's welcome Dr. Yan Li, Managing Director of USCACA and CMO of Bioscience, to make opening speech. Dr. Yan is a seasoned drug developer. He's my long-term friend. He held the executive position at the GSK, Merck, and J&J. Most recently, the VP of Global Oncology Head, Unit Physician of GSK. He contributed to the development and approval of numerous medicines, including Keytruda for China. He firmly believes in the power of global collaboration. He is a graduate of Peking University Medical College, where he has adjunct professor. He's adjunct professor. He's also alumnus of Harvard Business School Enterprise Leadership Program. Let's welcome Dr. Yang.
Thank you, Dr. Chen, for the initiative. Good morning and good evening, dear guests. My name is Li Yan. I'm the Managing Director of the U.S. Chinese Anti-Cancer Association. My warmest welcome to all of you to this special event. The COVID pandemic has certainly had a major impact on our lives business, but our battle against the cancer did not and will not stop. Our collaboration among physicians and scientists between US and China and beyond will not stop. And our efforts to advance innovative treatment options for our cancer patients will not stop. Today's event
It seems we lost.
Hello?
Yeah, okay.
Oh, yep. It's back, okay. And together with American Association for Cancer Research, the AACR, and American Association for Clinical Oncology, ASCO. So today's event is a testimony that pandemic will not stop our fight against cancer as a global community. I am very confident that we will beat COVID. Bree Biosciences is a small startup company where I have the honor to serve as a chief medical officer. We developed an antibody cocktail against the COVID, and in less than 20 months, the drug went through concept to full approval in China, and we're obtaining the EUA in the US. And I have the same confidence that our joint global effort is going to beat cancer. So I look forward to hosting this event in 2022 and welcoming all of you in person to join us next year in China. Thank you.
Thank you, Dr. Yang, for the great opening speech. Okay, now let's begin the presentation session of this symposium. Before that, I want to share with everyone some webinar tips. For your question and answers, open the Q&A window. Ask the questions to the panelists. They can either reply back to you by text in the Q&A window or answer your question live. For Chinese language interpretation, click language interpretation, then choose Chinese option. English language interpretation, if any panelist speaks Chinese, click language interpretation, then choose English option, so you will get what you want. So let's welcome the first speaker, Dr. Jihui Hao, the president of Tianjin Medical University Cancer Institute and Hospital. Dr. Hao is the chairman of Tianjin Anti-Cancer Association, distinguished professor of Changjiang School Ministry of Education, winner of Outstanding Young's Program of National Electoral Science Foundation, deputy director, the Society of Pancreatic Cancer Committee, China Cancer Association. He's also deputy director, the Society of Precision Medicine Committee, China Cancer Association. His presentation topics today is surgical strategy based on multiple approach for neoadjuvant therapy pancreatic cancer patients. One way or all roads lead to Rome. Dr. Hao, please.
Good morning, everyone. I'm honored to be here to share with you my thoughts on surgical strategy for pancreatic cancer after neoadjuvant chemotherapy. Recent years, we focused on two issues around precision neoadjuvant chemotherapy for pancreatic cancer patients. One is how to prolong the survival of pancreatic cancer patients after neoadjuvant. The other is how to improve the efficiency of neoadjuvant chemotherapy. Talking about pancreatic cancer, it is devastating malignancy with desperate prognosis. It's global malignancy with a sharp increase in incidence. Pancreatic cancer is also the fourth leading cause of tumor-related deaths and will reach the second by 2030. The median survival time of pancreatic cancer is 8 months with 5-year survival rate of 8%. At present, there is no need to debate for the predominant position of neoadjuvant chemotherapy in comprehensive treatment of pancreatic cancer. Since 2016, ASCO, the concept of potential curable pancreatic cancer, had been referred based on the neoadjuvant chemotherapy. After that, neoadjuvant chemotherapy in PDAC turned to be a hot topic for ASCO, and multiple clinical trials have been designed. Neoadjuvant chemotherapy has also been gradually extended from locally advanced and borderline resectable pancreatic cancer to resectable pancreatic cancer. Although the concept of neoadjuvant chemotherapy has tended to be perfect, there are indeed many difficulties in the implementation of neoadjuvant chemotherapy in clinic. For example, the patient on the left, whose CA199 is more than 1000 and the AI score is 7, has obvious pain. According to the high risk factors, neoadjuvant chemotherapy is obviously recommended, but the patient does not agree and demands for direct surgery. The patient on the right had a KPI score of 90 and MELS rates of CA199. No lymph node metastasis could be found. The attending physician believed that DPCAR could be directly performed to achieve R0 resection, but MDT discussed that neoadjuvant chemotherapy should still be given. We surgeons always seem to be torn between the putting down our scalpels and picking up neoadjuvant chemotherapy, and countless clinical trials are still testing 3 questions that remain unanswered. The first one is the choice of neoadjuvant chemotherapy regimen. The second one is the duration of neoadjuvant chemotherapy. And the third one is the choice of treatment if neoadjuvant chemotherapy fails. In our center, we are currently conducting some trials for neoadjuvant chemotherapy for borderline resectable and resectable pancreatic cancer, and have gained some experience and data. In our center, the modified FOLFIRINOX is the first choice, especially for patients with high risk factors, and Abraxane combined with gemcitabine is also the first choice for neoadjuvant chemotherapy. In particular, for patients with poor general status, some patients also used Abraxane combined with S1 regimen, and patients are still being recruited for this clinical study. After neoadjuvant chemotherapy, we generally would perform enhanced CT scan and circulating tumor cells detection for assessment after 2 to 4 cycles. So operations would be performed in 2 weeks after the neoadjuvant chemotherapy. For patients who fails in the treatment, we would replace the first-line chemotherapy or recruit them into new clinical trials. We have reviewed the survival of nearly 800 patients' data. The mean survival of 352 patients receiving chemotherapy alone was 10.61 months, compared with 20.24 months for those receiving direct surgery, and 25.43 months for those receiving neoadjuvant chemotherapy. The 3 major topics I want to discuss today are the 3 problems that the neoadjuvant chemotherapy brings to our surgeons. The first one is what to do in cases with stable imaging evaluation after neoadjuvant chemotherapy. The second one is how to manage the cases with suspected arterial involvement after neoadjuvant treatment. The third one is how to choose expanded or standard radical surgery after neoadjuvant chemotherapy. So let's start the first topic with a case of a 61-year-old man with pancreatic head cancer. The TNM staging is T3N1M0, who received 4 cycles of neoadjuvant chemotherapy with gemcitabine plus Abraxane. From CT scan, we diagnosed the patient as a borderline resectable pancreatic cancer. We look at the CT of the patient after 4 cycles of chemotherapy. The measurable lesion were evaluated as stable, and the tumor still suspected as invasion to the right posterior wall of the portalway. What should we do next for such patients? For this patient, we conducted the detection of circulating tumor cell before and after chemotherapy and found that after neoadjuvant therapy, the CTC was halved. After the end of chemotherapy, we also performed another time of biopsy for this patient, and the pathology showed multiple necrosis around the tumor tissue. So we judged that this patient had a response to the neoadjuvant chemotherapy. With exploration, we found no metastasis. Then we performed pancreatic duodenectomy plus level 3 SMD, and the right half of the superior mesenteric artery was dissected for 180 degrees. A total of 28 lymph nodes were collected. It was confirmed that the tissues after neoadjuvant chemotherapy were poor and fragile, accompanied by inflammatory reaction, and it was easy to hemorrhage when touched. But there was still tissue space. Finally, pathology confirmed that the pancreatic cancer of this case reached pathology stable, and only 2 lymph nodes are positive. The change of CTC in this patient was consistent with the response of neoadjuvant chemotherapy. Therefore, we collected CTC data of total 32 cases of pancreatic cancer before and after neoadjuvant chemotherapy, and then statistically analyzed the correlation between the imaging results, pathological results, and absolute value change of CTC. It was found that there was no difference in the absolute value of CTC changes between the imaging stable and the PR groups, but there was a statistical difference in the absolute value of CTC changes between the 14 pathologically stable patients and the 12 PR patients in the imaging stable group, which suggested that the significant change in CTC during the imaging stable may indicate the pathological benefit of the patient. Radical surgery can be attempted for this patient, but the sample size of the study is small and further confirmation is needed. For surgeons, the selection of regimen for neoadjuvant chemotherapy is always difficult. This year, we have published a paper in pancreatology. In this study, we found that the delta HU is a potential marker to predict the chemotherapy response for PDAC patients. The delta HU is defined as a difference value for venous phase HU and balanced phase HU in enhanced CT scan. It is positively correlated with microvascular density, which is correlated with a good response for Frenox regimen because more agent would enter the tumor through the stroma. In our single center cohorts, totally 179 cases, the cutoff value of delta HU is 27. That is to say, for those PDAC patients whose delta HU are more than 27 showed better response in FOLFIRINOX. Talking about stroma and the cancer cell, we are curious to know who is the real enemy for neoadjuvant chemotherapy. Let's see this patient who received 6 cycles of Abraxane combined with gemcitabine. The imaging evaluation suggested that it is a PR case with significant shrink of tumor. But after operation, the pathological result indicate that the stroma is more shrinked, obviously, yet no significant necrosis was found in cancer cells. Let's see another case who received 4 cycles of modified FOLFIRINOX. The imaging evaluation suggests a stable case with no significant change in tumor size. However, after radical resection, we did find necrosis in cancer cells yet no stroma shrink was found. This opposite result should take up into a deep think. Shall we focus more on stroma evaluation during the neoadjuvant chemotherapy? Okay, if we talk about stroma in PDAC, immune cells play a major role in it. We also took a look at the change for panel of immune cells after neoadjuvant chemotherapy. We compared the results for multiple-labeled immunofluorescence in 37 neoadjuvant cases with upfront operation cases. We found in those who received neoadjuvant chemotherapy, the CTL, DC cells, as well as M1 macrophage cells were increased around tumor compared with upfront cases. In the other hand, Treg and MDSC cells were decreased after neoadjuvant chemotherapy, while M2 macrophage cells showed no increase. These results suggest that for those patients who may benefit from neoadjuvant chemotherapy, the change of certain immune cells may be a good predictor. The case promoted us to extend our thinking. How could we perform a more safe and radical operation for neoadjuvant patient with stable imaging evaluation? Many factors affecting the safety and the radical treatment of the operation are taken into account. The two most relevant factors should be the choice of the approach and the recognition of anatomical size. The reasonable combination of the choice of the approach and the recognition of the necessary anatomical landmarks can often facilitate radical operation of PDAC after neoadjuvant chemotherapy. Here, I share a video to illustrate my thoughts on radical resection for pancreatic body cancer patient who received laparoscopic distal pancreatectomy after neoadjuvant chemotherapy. So this is a good example for operation based on landmark and approach. I think that during radical resection for distal body or tail of the pancreatic cancer, there are some landmarks that we could refer to. The first one is the splenic artery. The second one is the splenic vein. And also the portal vein and the SMV should be recognized. And the toad space and the Jiuwei space should be the space that we should enter into and by using these landmarks. Here we would build a channel between the superior mesenteric vein and the neck of the pancreas, and then we cut off the pancreas. During the posterior ramps, the adrenal gland would be resected, accompanied by the distal pancreas and spleen. Time is limited, so we should stop here and moving forward. Okay, now let's look at the management of artery involvement after neoadjuvant chemotherapy. The vessels involved are usually the celiac trunk, the superior mesenteric artery, and the ectopic hepatic. According to the AGCC staging system, the patients with arterial involvement were classified as T4, which belongs to the stage 3. Tumors of the head of pancreas or ascending process are more likely to invade SMA and the ectopic right hepatic artery, while carcinoma in the neck and body of pancreas is more likely to invade celiac trunk. After neoadjuvant chemotherapy, if the tumor regression is not obvious, DPCAR, dissection of the ectopic right hepatic artery, evaluation of SMA or reconstruction of the hepatic artery. The anatomical basis of DPCAR surgery is to maintain liver blood supplied by SMA, GDA, PHA arteries. The key points of DPCAR were to maintain the blood supply of both liver and stomach, and to completely dissect the posterior space of the neck and body of the pancreas to achieve an R0 resection combined with reps. One of the key points of DPCAR surgery is the management of the left gastric artery. Some centers preoperatively embolize the left gastric artery to establish collateral circulation, while others use the middle colon artery for reconstruction or direct anastomosis of the left gastric artery. There are two reasons for doing this. One is to protect the blood supply of the stomach. The other is to prevent the gastric stooling caused by compensatory thickening of the right omentary artery after the left gastric artery is served, which affects the blood supply of the liver. So this is an example of a patient that performed apple-bite surgery after neoadjuvant chemotherapy, and we can see that with the dissection of the involved abdominal tract, the entire posterior peritoneal margin was completely dissected. We believe that the SMA involvement in patients with surgery after neoadjuvant chemotherapy should follow the process listed here. First, we rule out the number 16 lymph node metastasis, distant metastasis, and then we suspended the left renal vein, then mobilize SMA from the roots. We would open the longitudinal chest of SMA to check an instant pathology. If the arterial chest is negative, we would thoroughly review the Harbour triangle and perform a radical resection. However, if the arterial chest is positive, the radical surgery is abandoned and the palliative surgery is performed. So the radical surgery based on the triangulation principle was proposed by Professor Buchler from Heidelberg University. The principle indicated that SMV, SMA, and the common hepatic artery compose a triangle area in which contains a large amount of soft tissue and lymph nodes. Exposure to the region also means that the SMA right side reach a thorough cleaning. and dissection. Finally, we would discuss the topic of standard or extended surgery for patients after neoadjuvant chemotherapy. In fact, many different attitudes existed in the academic fields regarding surgical dissection of pancreatic cancer, including the standard radical resection advocated by American scholars, the ultra-radical resection advocated in Europe, and expanded dissection advocated by Japanese surgeons. Several theories have their basis. So which idea should we hold for the cases after neoadjuvant chemotherapy? Personally, I think in the era of neoadjuvant chemotherapy, this should no longer be an academic controversy, rather than a pattern of thinking. The borderline resectable pancreatic cancer and the locally advanced pancreatic cancer cases required extensive resection to achieve R0 resection and neoadjuvant therapies. Besides, extensive dissection can obtain most comprehensive specimen, including lymph node, nerve, soft tissue, and etc., and avoiding staging drift. Finally, objectively evaluated the effect of neoadjuvant chemotherapy and formulate a revised adjuvant therapy plan. We should also need to be aware of that the extended dissection of pancreatic cancer after neoadjuvant chemotherapy was only part of comprehensive treatment to prolong the survival. Totally 6 homogeneity should be achieved. They are namely as chemotherapy regimens homogeneity, lymphadenectomy homogeneity, the CART8 homogeneity, lymph node sorting homogeneity, pathological evaluation homogeneity, and whole course management homogeneity. Only when all of these 6 homogenizations are achieved, the effect of neoadjuvant chemotherapy for pancreatic cancer could be maximized. Of course, we should also objectively evaluate the complications of enlarged radical surgery, including postoperative diarrhea, lymphatic fistula, gastroparesis, pancreatic fistula, postoperative bleeding, and etc., which requires careful postoperative management. Okay, that's all what I want to share with you today. And here I list some take-home messages of today's topic. Thanks for your attention. Thank you.
Thank you, Dr. Hao, for the terrific presentation. Shared with us his in-depth research in his institute and also comprehensive review, innovative perspective, neoadjuvant therapy for pancreatic cancers, one of the most tough cancers, especially the evaluation strategy for the clinical response artery encasement, including some even the translational evidence. He also pointed out, between standard or enlarged, strategy. So what is the choice and for the clinical, which is very insightful for us to continue thinking beyond even in the clinical practice and also continue innovation to bring additional benefit to patients to the therapy. Thank you. Next one, let's welcome next speaker, Professor David Tuveson, Director of Cold Spring Harbour Laboratory Cancer Center and the President of American Association of Cancer Research, AACR. Professor Tuveson is also the Chief Scientist for the Lustgarten Foundation in Woodbury, New York, the largest pancreatic cancer research philanthropist. Dr. Tuveson is a medical staff affiliate at the Memory Sloan Kettering Cancer Center in New York, and also works closely with the Cancer Institute of Northwell Health on Long Island. Dr. Tuveson serves on the board of the scientific advisor of National Cancer Institute. He is a world-renowned physician scientist whose basic and translational research focuses on increasing our understanding of biology and of pancreatic cancers and on identifying, testing in preclinical and clinical settings, new approach for diagnosing and treating the disease. His presentation topic today is discovery science driving clinical breakthroughs. Dr. Tuveson, please.
Thank you very much, Dr. Chen, for the honor of meeting with the Chinese Anti-Cancer Association today for your annual meeting. I am here representing the American Association for Cancer Research, where I have the great pleasure of serving as their president for this year. I really enjoyed the presentation before me about pancreatic cancer, since I spend all of my time working on this disease. And it was terrific to see the advances that were being discussed in the neoadjuvant space. I think when we can give some proper medicines to all the pancreas cancer patients beyond the classic chemotherapies, I think we'll start to see that neoadjuvant therapy is going to play a very big role in resectable and non-resectable patients. But today I'm just going to give you some highlights of how the American Association for Cancer Research has been working to further the research agenda of all cancer scientists and cancer physicians throughout the world. I will discuss some of the findings from our annual report and hopefully give some topics that we can discuss when we have our roundtable a little bit later. So again, thank you so much for inviting us to participate. I apologize that it's not in person, as already discussed by Dr. Li Yan. And I think that it will occur in the future, hopefully next year, as we continue to battle this bloody virus. So it is true. We continue to work on cancer despite the COVID virus. We all do. We all take care of our patients. We all run laboratories and institutes. And you know, we continue to do the work we started before the pandemic. The pandemic has made us focus, though, I would say differently. So again, how have we been doing in the war or the battle against cancer? Well, in the United States itself, we've had some progress. And as shown here on this slide, our death rate, our overall death rate of all types of cancer has gone down by almost a third. And this equates to over 3 million lives saved. And so this is a great advance. Now, unfortunately, most of those lives are not pancreas cancer. We still have a lot of work to do in pancreas cancer, as just mentioned. We in America have 16.9 million cancer survivors, which is quite a lot. And these individuals motivate us to double that number, triple that number. And this is, again, because our survival rates have gone up. And it's gone up from 50% from the 1970s to 70% over the last decade. That's a big change in our survival rate. And even amongst the young, children, adolescents, the 5-year survival rate has gone from 63% back in the 70s to 84% just over the last 10 years. That's a big increase. And this is something we are obviously happy with. And I suspect similar numbers exist in China. Now, what has happened over this last year? Why are the successes increasing? Well, some of it is because detection is better for certain cancers where you catch it early. Prevention has helped so that primary prevention, for example, so certain cancers are going down. But I would say the therapy side, the therapies have gotten better. And over this last year, we've had 16 new therapies approved by our Food and Drug Administration for cancer. We've had 11 previously approved therapies for other types of cancer that then got applied to a different one. We've had 3 new diagnostic imaging agents, 2 new surgery-guided devices, and we're starting to see the computational side of things really pick up. We've had 1 new artificial intelligence-driven endoscopy device that was approved by the FDA. And then finally, the diagnostics, the liquid biomarkers, the companion biomarkers, they are really becoming popular. And we had 2 multi-gene panels approved this last year. And so how are we making this progress? Well, nothing is in isolation. We have constant communication between the laboratory and the clinic and patients on clinical trials back to the laboratory. That's really been, I would say, the map that has allowed us to make successes. And the same is true in China. It's really, again, this process that we've developed over time where the laboratory is not isolated from the clinic and from the patients. And that's where we, again, are making our breakthroughs, innovation in our discovery science. Our knowledge of cancer has gotten to the point where our scientists can talk to doctors. And so I'm going to just give you some highlights of some of these targeted therapies, which, again, you think of as small molecules. These are the kinase inhibitors, et cetera. There's more to targeted therapies than that. I would say the antibodies has become targeted therapies because they can deliver cytotoxic drugs so that we can just treat the cancer cell and not the whole body. And again, the major problem we have with chemotherapy is not that it doesn't work. It works great. It's toxic. We can't give it every day. This is the major problem, the therapeutic index. And so we can increase the therapeutic index with antibodies and other ways to deliver therapies. Liquid biopsies, again, means mostly blood sampling. There are other fluids in your body, though, that you can sample from. I will talk about that. Immunotherapy. We've heard about it already today. Immunotherapy has really become, a mainstay of the treatment of many types of cancer throughout the world. And there are multiple types of immune therapy. I'll just talk about two of them today. The sort of first one to get a big breakthrough, which are the antibodies to modify the attenuation of T-cell responses, so-called checkpoint inhibitors, and finally synthetic biology approaches where you're actually modifying T cells and other cells to kill cancer cells. And so over the past, several decades, I would say the knowledge that allowed us to make these advances really lied at the molecular biology revolution, where we learned how to sequence a genome, and then we learned how to sequence cancer genomes, and then many of them. And it's led to, in the US, something called the Cancer Genome Atlas, that is essentially a compendium of many tumors analyzed by many scientists and researchers, and have been, annotated properly and thoroughly reviewed. And this is sort of, a book on the shelf that allows one to get started when you study a particular cancer type. You're looking for the causes of cancer, the genes that are mutated, for example. And the Cancer Genome Atlas, as I said, is a comprehensive catalog of the breadth of genetic alterations that show us the drivers and genes involved in progression. The discovery efforts of the Cancer Atlas have coincided with the development of the targeted therapies. They provided knowledge to scientists and corporations to develop medicines, because these could be the Achilles heels, the vulnerabilities to cancers, which really heralded this whole new era of precision medicine that links the genome of each patient to a drug for that patient. And this is, a great start for many of our patients. And so if I were to look on a very simple diagram, starting with the National Cancer Act signed by our former president, Richard Nixon, in 1971, and then go 50 years into the future to today, what have we done? Well, we signed the Cancer Act and we tried to figure out why cancer existed. So we looked for a cause, and the cause led us to identifying different types of cancers, different ways it was transmitted. For example, in mice and rats, we could identify a virus that passed on a cancer, which we call it the Kirsten rat sarcoma. Well, almost 10 years later, we found the gene that caused this cancer, which was KRAS. And there were multiple mutations in KRAS, all on, most of them on codon 12. And so we knew that in 1983. And as the genetic engineering part started to work, we could sequence tumors. We realized that pancreatic cancer had 90+% KRAS mutations, as shown here. And the clever biologists in their laboratories could take a mutant RAS gene and turn a normal cell into a cancer cell. Very fundamental observations. We could show correlation and follow that up with causation. Well, at this point, it's still scientific knowledge, has not helped a patient yet. Well, we could take that gene and then make mouse models that got lung cancer, for example, and eventually pancreas cancer. And we could take that knowledge and start to develop chemical therapies that could hit RAS. And so this is really the breakthrough moment here in 2013. There was an academic in the States, Keyvan Shokat at UCSF. He developed a chemical that could stop the KRAS mutation of glycine to cysteine. Of course, this led to companies getting involved, and then multiple companies came up with good inhibitors. And we actually now have several approved. The one this slide is about is sotorasib, and it was approved just this year for the treatment of lung cancer with this mutation. Many patients are positively affected by this medicine, and perhaps Dr. Vokes will talk about that in his presentation. But this was actually bench to bedside, over 50 years. Okay, and it takes that long to actually go from what is cancer to this causes cancer to we have medicines that would stop cancer. Well, is there other ways to make targeted therapies? And I alluded to this before, that therapeutic index is the key thing here. If we could deliver medicines to cancer cells, lots of things would work to make the cancer go away. But how do you specifically do it? Well, you could use antibodies. We just heard from one of our colleagues who made antibodies to COVID-19. Well, what about making antibodies to cancer, like specific antibodies? So here are some antibodies that bind. This would be a B cell cancer, CD19. Here's a myeloma cancer with this cell surface protein, BCMA. And then finally, urothelial bladder genitourinary cancers have a membrane protein called TROP2. And then, of course, our old friend HER2, which is amplified in a subset of breast cancers and occasionally on other cancers that are not breast cancers. All of these proteins are bound by monoclonal antibodies that are made and produced by academics and corporations. If you put medicines on these antibodies, you can deliver that antibody to that cancer. And these are 4 approvals over the last year of antibody drug conjugates, which actually help a lot of patients. It's amazing it's actually taken us this long to develop this approach. Ron Levy ages ago made radioisotope labeled antibodies to ablate lymphomas by using anti-idiotype approaches. But for some reason, that concept really has taken a long time to take hold. But now we're starting to see it. And so this is really an amazing approach that I think is going to be critical for many patients. So what about the ways we follow our patients? Well, this is really important. We all use stethoscopes to listen to the heart, blood pressure cuffs to see what the blood pressure is. How can we find out if the cancer is responding to our medicines? How much cancer is in the blood? Well, we have these approaches for doing it in the blood where we can measure the cancer content either as cancer cells or as genes that we can measure in the blood. And so this little cartoon is supposed to show you that. The tumor extravasates into the bloodstream, spreads through the body, and metastasizes. Whenever it spreads, many of the cells die. You can see the contents of the cancer cells, such as cell-free DNA. You can, the occasional cell that does survive, you can measure. And there are proteins obviously made by the cancer cell. And so, you're doing liquid biopsies to follow the patients. How sick are they? Are they responding to the medicine? Has the cancer come back? All of these sorts of things. Critical. Developing the technology for this is easier for me to describe than the effort that was involved in it. And we still need, I would say, better ways to do this rapidly for all patients. But this is really a huge part of how we manage many patients today. And this started with basic science leading to clinical applications. One of the diseases where we want to do these liquid biomarkers are the patients treated with immune therapies. Immune therapies are a big deal. They have helped many, many people who would no longer be with us. They have saved many people, particularly in melanoma, where they first were developed, these checkpoint inhibitors. But it is now goes into lung cancer. Smokers with lung cancer do respond to immune checkpoint inhibitors. And this, again, started way back when we signed the Cancer Act. The government in America said, get to work, try to figure out what causes cancer. And when you're ready, try to develop the medicines that will go after the causes. Well, one of the things we knew right away was that the immune system wasn't working properly in people with cancer. It had failed. Possibly part of that is part of aging, because cancer is a disease of elderly, and the immune system tends to also run out of steam as you get older. But another part of it is cancer is immune suppressive. It actually evades the immune system by a variety of mechanisms, locally as well as throughout the organism. Well, the immune system was kind of discovered in parallel, like parts of the immune system newer parts using genetics. The MHC locus was cloned, for example. The T cell receptor was cloned, and the B cell receptor, all of that. How T cells worked to start an immune response and to stop an immune response were developed. And that's important because if the T cells just go crazy, you have an autoimmune disease and you're not viable. You will die of autoimmune disease. And so the brakes on the T cells were identified, CTLA4, PD-1, and scientists invented antibodies that could block the ability of those proteins to bind their cognate protein on the cancer cell. And so CTLA4 and PD-1 are T cell proteins. And so the antibodies were developed, they were tested in model systems. Jim Allison had this very famous science paper where everyone went off for the holidays and someone came back and all the mice were saved. And they thought they had swapped the mice out, but actually the mice had responded. They had a cure of a melanoma cell line by the first CTLA4 antibody in mice. Well, I mean, this was amazing. And this was developed clinically. The humanized antibodies came out, and some of the first patients survived even today from metastatic melanoma. And PD-1 similarly had a similar kind of story in the back. And these are both the antibodies that are really the mainstay of immune checkpoint blockade today. PD-1 directed antibodies and CTLA4 directed antibodies. Started out with just a few antibodies, and now we have eight inhibitors approved. And of course, Jim and Dr. Hanjo won a Nobel Prize, for their work. So this was, amazing. Immune therapy is terrific, but it doesn't help every patient, and it is toxic. And so again, it kind of put our foot through. The door is open, but not everything is through. We still have a lot of work to do in the immune therapy space. Many cancers are not responsive to immune therapeutics, for example. Pancreas cancer, great example. And so we have to figure out why immune therapy only works in some cancers and not others. Part of it is the number of neoantigens, number of mutations, but there's more to it than that. Are there other ways to get the immune system work? Absolutely. Synthetic biology, so-called chimeric antigen receptors can be made, where the T cells shown below here, which usually sees a peptide presented by MHC, can be rewired so that now on the outside it has an antibody, for example, that sees the tumor cell. So it's almost like antibody-directed cell therapeutics, but it's really antibody-directed a cell-based therapy where it actually brings the cell with it, not just a toxin. And so in the last year, there have been several approvals, one to treat myeloma, one to treat B-cell lymphoma. This is actually an amazing therapy for the patients that have certain cancers. And there have been, fabulous stories told about the patients that do benefit from these. Will this be the future for all cancer? I don't really know. I mean, solid tumors are really hard to go after with synthetic biology approaches. The tumor microenvironment in solid tumors is very immune suppressive. So I don't think we can just send in these cells and hope they're going to win. The analogy I use, although it's not terribly politically correct, is bullfighting. And so in bullfighting, the matador never goes in first. It goes in last. And I think of the immune system in the same way. We should weaken the cancer using targeted therapies and stromal therapies, and then enable the immune system to actually go in and pick off a damaged and wounded cancer cell. That's what the immune system will be good at. That's just a simple comment, but that's how we think about things, certainly in pancreas cancer. But, again, these were major advances over the past year. Where else can we go with synthetic biology? We can go a lot of places. We can do CAR Ts using T cells. We could use NK cells and NKT cells. These are things that are occurring right now. They're also using myeloid cells to use chimeric antigen receptors on the surface, which obviously would kill in different ways. And so really the sky's the limit here. Well-designed clinical trials will be critical. And my understanding is in China, a lot of this is occurring too, which I'm happy to hear. So where are we going in the future? Well, I said in the beginning that we're helping a lot of patients. A lot of people are alive today that wouldn't be today, but we still lose a lot of patients. We're losing 600,000 people a year in the United States. And you're losing more in China. You're a much bigger country, right? So, we have work to do. So we have work to do on all levels. we still have things to learn. We need to investigate cancer biology a little more deeply. I've alluded to this, but we need to understand the tumor microenvironment. The tumor microenvironment is the neighborhood within which the cancer cells live. It's all of the events there, all of the substituents. It's the stromal cells, the fibroblasts. It's every aspect of an immune cell, not just the T cells that everyone's excited about, the T lymphocytes, but the macrophages, for example. It includes the blood vessels. It includes, extracellular matrix, the lymphatics, et cetera. We need better ways to deliver cytotoxic agents. I just suggested one, which is antibodies, which are now being FDA approved to deliver the payload. There are other ways to deliver things. This is where scientists should really get involved and work with corporations that develop these. We need new therapies. So the RAS therapy, the G12C therapy, sotorasib, it hits a cysteine. It covalently binds a cysteine. Cysteine are very reactive. Well, there are clever ways to actually kill proteins now where you degrade them, protein degraders. And I hope protein degraders become not just a research project, but clinical projects where we can see them really progress. Now, mRNA vaccines is written here. Obviously, mRNA vaccines have helped us with the COVID pandemic, massive. Could they be useful to actually treat a cancer patient? What about to prevent cancer in patients? These are the questions we're asking today. I didn't spend much time on prevention and early detection. I kind of alluded to it. If we could prevent cancer, none of us would have jobs. That would be okay with me. But we can't do that today, right? We still have so much to do in this space. And I love the prevention topic. I mean, not enough study goes on in people with pre-neoplasia. We should study people with pre-neoplasia. They have measurable disease and they're not even that sick. But it's easy for me to say these things. It's harder to motivate the corporations and the government agencies, et cetera, to do those trials. Early detection technology is getting a lot better. We still need change. But the technologies are impressive in early detection, but we have work to do. Environment, lifestyle, and behavioral factors. Well, in America, obesity is quickly becoming almost our #1 risk factor for cancer. I don't know how it is in China, but we have this huge obesity problem. We have no clue how obesity causes cancer. None at all. No real clue. We say a lot of stuff, microbiome and metabolism and this and that. We really don't know. And so we have work to do on that topic for sure. We have an AACR task force actually looking at this. If you have any ideas, please send them my way and I'll get the people to study them. And then we have this issue about health disparities. So disparities, we see it in every country. And sometimes it's related to how people live. Like, do they live well? Do they have a roof over their head? Do they eat balanced diet? Do they have a chronic stress problem? And disparities, no one's free of it. Everyone has a disparity problem. Well, disparities is important and it should be addressed as so. We also have diversity. So diversity is how health is different in different races and different ethnicities. This is a big deal because this can be studied very scientifically. And, genetically, we are not all the same. We evolved to eat certain things in certain parts of the world. And when we bring us all together, things are a little bit different. So disparities, we have to try to separate the socioeconomic issues from the actual genetic and racial underpinnings of things, because I think collectively, that is going to be the richest envelope for us to move this forward. For example, in America, Africans don't get Barrett's esophagus nor lower esophageal cancer. Studying the genetics of it actually led to the understanding. They have a good gene, GSTT2. Europeans have lost it. And that's the type of thinking that I'm describing here. We have to start studying, people within their ethnicity so we can learn about the whole planet. In any case, I think that's probably my last slide, and I hope I haven't gone way over. I look forward to the later discussion session, but I give it back to the chair, Dr. Chen.
Thank you, Dr. Tuveson. It's just a fantastic presentations, really insightful. He covers quite a lot of things, therapy and diagnosis, and also preventions. And he shared with us a wonderful story behind all this, brilliant, most advancement in cancer therapies, and especially point out a sophisticated and understanding of the biology is essential to drive the breakthrough in clinical. From the bench to the bed, I think it's important. It's not just the past and also for the future. I'm looking forward to the panel discussion to Dr. Tuveson. Thank you again. So next, let's welcome our next speaker, Dr. Jiuwei, who is the director of the oncology department at the first hospital of Jilin University. Dr. Cui is the head of the key laboratory of biotherapy in Jilin province, deputy director of Institute of Oncology of Jilin University, vice chairman of the first Young and Council of the Chinese Anti-Cancer Association, standing member and standing committee member, and also secretary general of professional committee of cancer nutrition of Chinese Anti-Cancer Association. Dr. Cui, please. Her presentation topic today is clinical and translational study of cellular immunotherapy for cancer. Dr. Cui, please.
Okay. Thanks, Professor Chen and Daryl. I will share my screen. Okay, dear professors, and today I will just focus on some clinical and translational study of cellular immunotherapy. Just as Professor Tuveson said, in the solid tumor, actually, immunotherapy, especially cellular therapy, has faced a lot of setback. So today I want to focus on some studies in China and also in our group. I want to share some ideas to all. So we also know, adoptive cell therapy has taken advantage of the immune cells to eliminate tumors. So it take a more and more important role in the cancer treatment. So far, we also know the non-genetically engineered T cells, and also we also know some, genetically engineered cells, such as CAR T cell, TCR T cell, and also had been approved. So the landscape of cancer therapy, in this table has shown the global distribution of the gene and the cell therapies have been rapidly developed to treat solid tumor, and some have been approved, while most of them are still under clinical investigation. So in China, for example, there are some clinical studies of non-genetically cellular immunotherapy. Most of them are focused on NK cells and CACA cells, and also gamma T cells, NKT cells. So they do a lot of clinical trials. For example, this is a clinical trial of randomized this multi-center clinical trial focused on the CACA cell combined chemotherapy for the squamous non-small cell lung cancer. In this multi-center study, we have this combination, this improves PFS and OS. It can compare to the PD-1 inhibitor or combined with chemotherapy. So it also in this study also the addition of the NK cell or CACA cell to the chemotherapy, it didn't bring new side effect. So it's proved as a safety. So another example in our center, we have tried another clinical trial. We just focus on the NK cell combined PD-1 inhibitor, just treated as a second-line treatment for the non-small cell lung cancer. So in this study, we also confirm this combination is prolonged PFS. You see the median PFS is about 11.6 months. It's much longer than use the PD-1 inhibitor alone. Also, we can see if the patient get a response, we will get a prolonged response. And actually, we also can see the OR rate is about 45%, and also is higher than the PD-1 inhibitor alone. In addition, we also found a predictor, in the patient who will get better response, the NK cell on the PD-L1 expression on the NK cells is increase for the patient who get better response. So it indicates the PD-L1 expression on the NK cell after infusion can be a good predictor for the better response. So for the CAR T cells, we have seen around the world, the China and the US top the two. And among the CAR T cell, we can see the annual changes of the CAR T cell increasing annually, especially for the phase 1 study. So in China, there are a lot of a group have put forward, put efforts into CAR T clinical study, such as different antigens. And so, for example, this year in ESMO, Professor Ying has announced, the result of a Claudin 18 study. In this study, they got OR rate is about 60, and the median PFS is about 6 months. And so the overall survival is about 9.6 months. So it indicates, actually it's very hard to treat for the solid tumor, but it indicates CAR T have played a role in the solid tumor. So worldwide, there are a lot of studies has been performed, such as targeting different antigens and different methods around the world. But we know, although the study in the hematological malignancy, the CAR T had achieved remarkable success in them. But in solid tumor, they are faced a lot of setbacks and challenges, such as in the solid tumor, there are many anal targets on the tumor cells. So it is hard for us to find an ideal target antigen. And also, the CAR T cells entering into the tumor bed, but the tumor impressive tumor microenvironment will suppress the CAR T expansion and may cause the CAR T exhaustion. And also, the microenvironment also has physical barriers. That's hard for the CAR T to traffic to the tumor bed. So that's why in the solid tumor, less few successful studies has been succeed. So in our group, we have tried a clinical trial. Just we see that GCC is also a target antigen. GCC actually is a granulate cell C. It is universally expressed in the intestinal tissue of humans. And also it is highly expressed in the colorectal cancer patient. So we selected as a target antigen. It is a receptor for guanine and the uroguanine and the E. coli enterotoxin, plays a role in the fluid and iron homeostasis of the GI tract. So we selected it as a target antigen. Actually, this target is also, pay attention in this field. In the primary modality for the GCC-direct cancer, it does as a target antigen, for example, ADC drug, and also antibodies and vaccines, and also other CAR T cells. But most of them are in the preclinical study, and none of them get success in the clinical study. So in our design, we just thinking about, previously we have found that the CD19 CAR T, when treated the patient with BAL, we also can observe the non-transduced T cell expansion. So in this way, we want to enhance the proliferation of the CAR T cells. So we design the coupled CAR T cells. In this design, we can see we not only can express the CAR against the GCC, this tumor antigen, we also design this CAR also express the CD19 single chain antibody that's targeted B cell. In this way, we can enhance the T cells proliferation. We also design some cytokines and chemokines expressed. In this way, are engineered to release cytokine and promote CAR T cell proliferation, infiltration of the tumor and the killing target cells. This is design. In the preclinical study, we have seen this couple of CAR Ts can improve solid tumor CAR T cell proliferation and also increase potential for durability of the response. So the T cell get fitness. So also in the animal study, we also see an enhanced anti-tumor activity. So how about in the clinical trial? So we designed another phase 1 dose escalation study. we just enrolled a patient with the metastatic colorectal cancer after second-line therapy. In this study, we just gave the patient some conditioning regimen, and then we just infused autologous CAR-T and see the response. The primary endpoint is about safety and OR rate. We just evaluated the patient response every 3 months by CT or PET-CT. The tumor was evaluated by RECIST criteria and PERSIST criteria. So these are the characteristics of the patient at baseline. 15 patients were enrolled, and most of them just suffer from metastatic CRC, and most of them experienced more than 2 lines of therapy. They just get refractory to the common therapy. So how about the result? We can see the safety first. The safety, we can see the CRS, most patients have suffered from CRS, but fortunately, most of them just grade 1 to 2. And about 86% of 7 patients get CRS. And also we can see in the high dose group, we also 1 patient developed grade 4 ACANS. Another way is immune cell associated neurotoxicity syndrome. But this patient was recovered by high dose steroid. Another common side effect is diarrhea, because we know this GCC is highly expressed on the intestinal epithelial cells. That's why, as most patients just suffer from diarrhea, and we can see more than 86% patients that suffer from diarrhea, and grade 3 and 60%. But most of them are just resolved by, we just use antibody against TNF alpha. Within 1 week, all of them just recovered. So we can see we also detect series, the panel of the cytokines, such as interleukin 2, 6, and 8, and some chemokines. The changes of these cytokines and chemokines is consistent with the CRS appearance. So let's see the efficacy. So in generally, the OR rate is about 40%. In the low dose, we can see 20%, 25%. But in high dose, we can see more than 50%. So the DCR rate in those two, we can see 100%. And in another way, most of the patient has been controlled. So we can see the spider graph. We can see the patient, if they get response, they will get further response with time going on. And another, we also evaluate the tumor by PERSIST criteria. The patient will get more response by PERSIST. We see in the dose 1L low dose group, 50% patient get PMR, and the high dose group, and we can see 85.7% patient get PMR. So also to see if the patient get response, it will prolong this response with time going on. So for example, one of the patients on the left side is a patient that just suffer from CRC because it has experienced 3 prior lines of chemotherapy. He is refractory to all the conventional treatment. So just enrolled in these clinical trials, we can see he get PMR. And baseline, you can see it has mass in the lung, in the liver. After only one infusion of the CAR-T, we detected response at 1 month. We can see get a PMR. And then we detected in the 3 months later, they can get further response. Another example on the right is a female. It also, refractory to all the conventional therapies. He also received 1 dose of the infusion. After 1 month later, he get, PMR. And further, at 3 months later, he post infusion, he get further a response. And both of the patients just go through CRS grade 1 and no neurotoxicity, but diarrhea is also well controlled. So we also raise another question. Can these CAR T cells enter into the tumor bed and perform their function? So we do the single cell analysis from patient biopsy before and after CAR T cell infusion. So we see post-infusion in the tumor bed, the cancer cell decreased, reduced. And also at the same time, we can see the CAR T cell in the tumor bed increased, and also in the peripheral blood. And another, we also see detected TCR clonal. We also see after infusion of the CAR T cells, in the tumor bed and also peripheral blood, there are more other new clones of T cells expansion. This also we detect no CAR T cells if they have activated. So we can see after the analysis, we can see the T cells, the genes associated with cell cycle or cytotoxicity has increased. It indicates the CAR T cell just experience activation. Also, the exhaustion genes decreased. So it also indicate the T cells have been activated. So we also detect other immune cells, such as macrophage. We just see, before the pre-infusion, there are a lot of M2 macrophages in the tumor bed. But after infusion, they are the M2 just transfer to M1 type of macrophage. Just another we also detected Treg cells. Treg cells also reduced in tumor tissue, and also we detect NK cells in the tumor bed. It also saw activation status of the NK cells. It indicated the environment after post-infusion of the CAR T cells had hot up. So summary, in our study, we have seen the couple CAR T cells was feasible and therapeutically safe. The most common off-tumor target toxicity was diarrhea, but this can be controlled by anti-TNF antibody, and couple CAR T cells demonstrate efficacy in the patient, and get OR rate in general is about 40%. But by persistent criteria in the high dose group, it get more than 80% response. But the PFS was not reached yet. And the couple CAR Ts could also in our study by the single analysis, we also confirm that CAR T cell can infiltrate in the tumor and cause tumor immune requirement hot up and enhance the immune response. So in general, we know immunotherapy has become a hotspot in cancer research, and the cellular immunotherapy are being rapidly developed. And advances in the field upon to permit new routes to generation of immune cells better equipped to effectively navigate barriers to treatment presented by solid tumor. Along with advances in the multifaceted approach, also we incorporated with cutting-edge biotechnology, it becomes possible for us to creatively exploit the immune system to fight against cancer and other disease. But here we must emphasize the importance of a cooperation among different fields. Thanks for your attention. And I would like to thank all my colleagues from my center, and also thanks for the collaborator for the innovative cellular therapeutics. Thanks for your attention.
Thank you, Dr. Cui, for the great presentation. We all know cell therapy has made great advancement recently, but the solid tumor is still a very tough target. And Dr. Cui actually provide a new technology as a double coupled and CAR T, and shared with us some initial evidence from preclinical, elaborate in detail the clinical evidence of their first phase 1 trials, including the clinical results and also some very impressive translational research. We're really looking forward to seeing more a successful story and provide the patients new options for them. They already been refractory to other available therapies. Thank you. Okay, so let's welcome Dr. Everett Vokes of University of Chicago. He's the president of American Society of Clinical Oncology, ASCO. Dr. Vokes specialized in head and neck and lung cancers. He is John Altman, a professor, chairman of the Department of Medicine, and a physician chief at the University of Chicago University, and medicine and also biological science. He is a former leader of respiratory committee of Alliance and served on the editorial board of several journals. He is a past chair of annual meeting education committee, annual meeting scientific program committee, and a member of the Conquer Cancer Development and the fundraising committee and the CancerNet editorial board. His presentation topic today is progress against cancer. Dr. Vokes, please.
Thank you very much, Dr. Chen, for this nice introduction. It's a great pleasure to be here today and to represent ASCO. I also can't resist, but I want to congratulate Dr. Kui on this remarkable work. This was very impressive, and I look forward to hearing more about it. I will talk a little bit about ASCO and the progress we've been involved in, and then show some examples of recent progress from areas that I've been involved in through my career, which is lung cancer and head and neck cancer. And where head and neck cancer is concerned in particular, some of the Chinese experience with nasopharynx cancer. Now, to remind you, ASCO is really a global network of professionals. We have 45,000 members, more than 150 countries, but we're very proud there is 500 or so members right here in China, and ASCO represents all of the subspecialties in clinical and basic science involved in cancer care. And our mission is to conquer cancer through research, education, and promotion of the highest quality treatment, prevention, and research. Now, you heard about the US National Cancer Act from Dr. Tuveson. This was signed in 1971 and really was a charge to unite the mission to conquer cancer, to do much of that under the auspices of NCI and a network of cancer centers that has grown over many years. And if you think back to where we were in 1970, we have really made tremendous progress. Now, in the 1970s, there were already some important discoveries. Radiation was established, early combination chemotherapy was established, curative treatment for testicular cancer was not far away, leukemia and lymphoma could sometimes be cured. But since that time, clearly much more progress has been made worldwide, and including in the United States. And there are all kinds of estimates, but one is that 14 million life years have been gained since 1980 from NCI-sponsored clinical trials in the clinical trials network, which I participated in for many years, the CLGB and the Alliance, and many others. Now, ASCO 2 has a cancer progress timeline. You see the website for that here at the bottom, and it chronicles the many changes going back really to before 1970, the beginnings with anesthesia, progress in surgery, progress in radiation, and then you go on to shorter and shorter time intervals from one major advance to the next, but clearly a really interesting 170 and longer time span of discovery and research. Dr. Tuveson already mentioned equity, and that has become a real emphasis at ASCO in last year's presidential theme with Dr. Pierce. I'm continuing that this year with the annual theme that will be very much present at our annual meeting this coming June in Chicago, which is to advance equitable cancer care through innovation, focusing what I hope will be a push of innovation coming out of the COVID pandemic, that crisis that affected cancer care so deeply, but may have in that process also led to progress and innovation, be it in care delivery through telemedicine, through more remote possibilities of taking care. We want to do this kind of innovation across geography. We don't care, is it rural, is it urban, what country it is in, across scientific specialties, and across the various care settings. We're also going, in terms of innovation, to continue the breakthrough meetings. We had our first one in 2019. It since has not happened, but it is now scheduled again for next year in Yokohama. And this is a meeting that very much will focus on new delivery methods, on artificial intelligence, on predictive modeling, on liquid biopsies, and the many other areas where we are together making progress against cancer. Now, you know about our annual meeting in Chicago and the JCO as our mainstay educational programs, but there's also Best of ASCO meetings. There's international clinical trials workshops to foster that in more and more countries, because that is, in the end, what helps us understand the laboratory advances that are so fascinating and bring them into clinical relevance, and then to try and help low resource areas with the assistance in resource guidelines, scientific development, and educational support. So some of the trends have been mentioned by Dr. Tuveson, who already spoke about the wonderful advances in immunotherapies, in molecular targeting, genetic signatures, combination therapies, and some of the examples we heard from other speakers. What I just want to focus a little bit about is first lung cancer and then head and neck cancer. And in my career, of course, we too have used the latest from laboratory, but I have frequently focused on the curative settings. And what do we do in curative settings? It's combined modality therapy. So surgery and radiation are frequently the mainstay of what should be done, but it is insufficient and leads to poor outcomes or insufficiently attractive outcomes for the majority of patients. And so we can add chemotherapy before, neoadjuvantly, after, adjuvantly, and during radiation, concurrent. And to talk a little bit about lung cancer, in particular non-small cell lung cancer, which is still the most common form. We have new disease and metastatic, where we do all the genomic sequencing, where we can use immunotherapies, we can use tyrosine kinase inhibitors. We can cure some patients with locally advanced disease, but we can cure a good number of patients with early stage disease using surgery, but not enough, because even then, many patients still frequently die. That's gotten a little bit better with the use of adjuvant post-operative chemotherapy. But what happened at ASCO this year is the first report of a use of a PD-L1 inhibitor in the curative setting after surgery and chemotherapy. And you see the design here, patients with early or kind of early 3A non-small cell lung cancer that got their standard surgery. Then they got up to 4 cycles of adjuvant chemotherapy, which is still standard of care. And then were randomized to either PD-L1 inhibition or best supportive care with a survival and progression-free survival or disease-free survival endpoint. And you see here the outcome at this point. Survival is a little bit too early, but disease-free survival was reported. And it can be looked at by stage. It can also be looked at by PD-L1 status. And here they looked at first, excluding the very early stage, 1B, looking at stage 2 to 3A, in those patients who had the target, best as we understand it, of PD-L1. And you see here a very nice increase in terms of the hazard ratio and also in terms of the p-value. If you include those patients that did not have PD-L1, but those that do are still included as well, then the difference is smaller, but it is still statistically positive. When the very early stage patients were added, it was no longer positive. And so the likely conclusion is that certainly for this group of people, and likely for this group of people in the middle, adjuvant PD-L1 inhibition using atezolizumab in this case is and will remain the standard of care in the near future. Looking a little bit more at the subgroups here, PD-L1 inhibition was seemingly of value, as I already mentioned. Those who did not have it didn't really benefit much. And then what we've consistently seen when patients have mutations, EGFR or ALK, and we know about it. We don't test in everybody, so there are unknowns. But when we know about it, that's probably not a group of patients that will benefit from this kind of treatment. Now, going to head and neck cancer, those of you who treat head and neck cancer will know this, but the nasopharynx is this part here at the very end of the nose and the top of the pharynx. And cancer in this area is endemic in some areas, including some areas of China. And there's been wonderful progress made in how to treat curatively this disease. This is a trial presented in 2019. It has since been published by Dr. Ma and his group, looking at induction chemotherapy using a regimen of gemcitabine and cisplatin, which is a regimen that previously was shown to probably be the best regimen in recurrent disease. And this was compared with cisplatin standard therapy and showed a superior outcome in terms of a recurrence-free survival as shown here, making that the standard regimen of induction chemotherapy for this disease. They followed that up and presented this year the addition of capecitabine adjuvantly after chemoradiotherapy using an innovative approach of metronomic chemotherapy. Now, this idea has been around a long time. As mentioned earlier, chemotherapy is toxic and we can't give it at all times. So what has been worked out over the years is, well, we give it every 3 weeks, and in the time in between, patients recover. Metronomic chemotherapy is a different idea where much lower doses are given, but they're given daily. And capecitabine is an oral drug, so that is particularly attractive as a such concept. So here, patients again got the chemotherapy, they got the chemoradiation standard therapy, and then after either received no further treatment or metronomic capecitabine. And you see here, for failure-free survival in an early analysis, that metronomic capecitabine seems to add beyond what standard therapy can give. So this trial supports the role for metronomic adjuvant chemotherapy, and it may be an option. I think there's a little bit more further validation and maybe a confirmatory trial required, but it is certainly a hopeful signal. Now, when induction chemotherapy curative treatments don't work and patients recur in head and neck cancer, up to now, we've given very toxic chemotherapy by itself. It's a regimen frequently called the extreme regimen, and it is quite toxic. although one can also use a regimen such as gemcitabine and cisplatin. This year at ASCO, Jupiter 02 was presented, and it looks at the addition of toripalimab, which is a drug developed in China, which is also a PD-1 inhibitor. And you see here the design. So patients have recurrent disease. So this is not curative. This is after curative intent treatment. And they got either the standard regimen of gemcitabine and cisplatin, or they got that same regimen plus a PD-L1 inhibitor, followed by maintenance. And we see here progression-free survival. So this shows a very nice difference in favor of adding the PD-1 inhibitor. Of course, you can argue it also shows just how much work there is still to be done for us. Once cancer is metastatic, we don't cure. We can prolong life, we can make people more comfortable, but we don't cure anywhere nearly frequently enough. And this is a early survival. Of course, it's not follow-up long enough, but again, so far already showing a difference in favor of the addition of a PD-1 inhibitor. So these authors concluded, and I agree, that toripalimab added to gemcitabine and platinum is superior to a prior standard of care and represents a new standard of care, also supported by similar investigations with pembrolizumab, as already published before. And just in fairness to mention a second trial that looked at camrelizumab, another drug under development in China, otherwise very similar design, maybe a little bit earlier in follow-up, but you see here progression-free survival also being encouraging at this point and supporting that this could be and likely will be for survival, hopefully as well, a positive clinical trial. So with that, I want to add ASCO and its global membership are committed to worldwide partnership. We want to advance equitable cancer care through innovation. I showed you some examples where this has been done, and I want to thank you for your attention.
Thank you, Dr. Vokes, for your great presentation, and help to remind us the wonderful journey and also the joint effort and the global work together to fight the cancers across the geography, across the care setting, and across the scientific discipline. Cannot agree anymore. So he particularly present some of the studies conducted by Chinese investigators. I remember by Dr. Zheng Ma, Dr. Ruihua Chu, and also Dr. Li Zhang for the left ovarian cancers, and is in his area. Thank you very much. Looking forward to the panel discussion. So next, let's welcome Dr. Fang Hui Zhao, and she's the Director of Cancer Epidemiology Department, National Cancer Center, Cancer Hospital, Chinese Academy of Medical Science. Professor Zhao focuses on the major scientific issues of cervical cancer prevention and control. She has carried out more than 30 population-based multi-center cervical cancer studies, and published over 180 peer-reviewed articles for over 20 years. She serves for a dozen of professional societies, including Asian Oceania Research Organization on Genital Infections, Neoplasia, Education Committee Chair, Asian Pacific Organization for Cancer Prevention, APOCP, etc. Professor Zhou leans her research interests toward global health, particularly to reduce the health inequity in vulnerable populations and also in low resource regions with her international training and working experience. In 2020, she has been selected as Everett's Health Woman Health Economic Research Prize winner. Congratulations. Her presentation topics is cervical cancer prevention in China, the path towards elimination. Dr. Zhao, please.
Okay, thank you very much, Charles, for your kind introduction. Good morning and good evening. I was impressed by the great achievements in the clinical oncology areas. But I'm also very glad to hear both the AACR's president and the ASCO president mentioned the importance of the cancer prevention and as well as the health disparities. So my topic is much more related with the prevention and also how to reduce the disparities across the world. But I will take China as the example. So now I think it's my privilege to invite you all to join me to the Journal of the Cervical Cancer Prevention in China. So I'm going to highlight the three key aspects within the next 50 minutes. What's the gap and the challenges of China to the global of elimination cervical cancer and efforts we have done in China, and also the predictive optimal pathway towards the elimination of cervical cancer. So last year, WHO has officially announced the accelerating cervical cancer elimination strategies, and China, together with other countries, have made a commitment to work together to eliminate the cervical cancer. And then the goal of the elimination is by this century, the incidence of the cervical cancer will be lower than 4 per 100,000. But right now in China, it's about 2.5 times the incidence higher. So and also benchmarking with the targets WHO set in 2030 for the from the national level for the screening coverage rate for the adult women is still less than 35, less than half of the targets of the WHO set. And also for the vaccination, we also can see for the girls under 15 years old, it's less than 1%. I think this is far more, from the vaccination, the targets for the HPV vaccination. And for the treatment, we do not have official statistical data available. But I think the coverage should be okay, but we need to be to make the high quality of the treatment. So that's the current situation. But beyond the gaps, and I think right now China's most challenging is facing the rising disease burden. And also for the cervical cancer, you can see the younger trend in the population. This is almost 5 years younger, no matter in urban or rural. So that's the challenging. And the challenges continue. That is the HPV surveillance we have done on the general population, female population. So we can see in January, HPV prevalence among the women aged 17 to 59 is about 17%. It's much higher than the average rate of the world population. And then if we compare to the prevalence with the United States, that have only one peak, the peak in the young population, because that's the sexual related infection. But in China, for the female population, you can see 2 peaks, not only in the younger the population, but also in the mid-age, around 40 years old. That's the population have the higher second prevalence of the HPV. So, and then the studies, the surveys we have done for the national young sexual behavior. So we can notice that actually we see very clearly trend towards the earlier sexual debut and the risky sexual behaviors in the young generations. So this is the cohort of the early 1990s. So I think that's for the millennia might be worse. So that's the huge challenges for China's right now. But however, we have also made great efforts to prevent for the cervical cancer prevention. So I think I believe the each country's efforts against the disease will be a vital lesson and also experience for others. So I summarized the China's efforts in the cervical cancer prevention and published in a comment on the Lancet, highlighting the importance of the interaction among the scientific research and also in innovative products and technologies development. And also the education and communication is more important to play the role in the cancer prevention. And the last, I think the policy orientation is also the key for the whole cancer prevention. That's the so back to the evidence of the cervical cancer. Our team started the studies since last 1998. And then we, that time is the evidence of the HPV and the cervical cancer is not, enough. So we conducted with the international collaborators together for the etiology studies and also the epidemiology studies for the HPV and the cervical cancer, the whole countries. And then we learned, we have the high disease burden, have the high prevalence. And also we understand, for the HPV genotypes, 16, 18 is the majority types for the cervical cancer. And this is the similar as the other regions. So that's these studies, evidence, I think, laid the scientific foundations for the introduction and development of HPV vaccine and also the HPV testing for the screening in China. So these tables shows the HPV vaccines in China. Actually, for the world, there's 3 vaccines are common available, like the MSD, Merck have the quadrivalent and bivalent, and also for the GSK have the bivalent. This is 3 vaccines, have been available for the world for over since 2006, and then last in the end of 2019, the Chinese made Xiamen Innovex. This is the 4th vaccines, be on the market for the world. So that's right now in China, we have the 4 vaccines available on the market. But however, I think we have more than a dozen multi-valent HPV vaccines in the development pipeline, so which could considerably increase the supplies and also reduce the cost of HPV vaccines, benefiting not only for China, but also to the other low-income middle-income countries. So thereby, I think they can advancing the prevention of cervical cancer worldwide. So that's the HPV vaccines developing in right now. So likewise, in the secondary and the tertiary prevention of cervical cancer, we also, our team also commitment not only to the high-tech research, but also to the approaches tailored to the lower middle-income countries, our areas, such as, we developed the fast and easy HPV test, together responded by the Bill Gates Foundation and together with our WHO colleges. So this is being developed and approved by the WHO pre-qualification. So we also explore the self-sampling HPV testing for the cervical cancer that can improve the screening coverage and the accessibilities. So that's a way also communicate lots of evidence and support the self-sampling can be used in not in the very remote areas. And also for the triage management of HPV positive women, that's also one way we want to explore more appropriate the biomarkers that can be reduce the over referrals of the HPV positive women to reduce the corpus copy and reduce the overdiagnosis and the overtreatment in the screening program. So that can be maximize the benefit and minimize the harms of the screening program in the general population. And meanwhile, I think for the treatment for cervical cancer is quite mature, but we still need a novel new treatment approach to access the population in the low middle income countries or low resources areas, because as areas is not able to treat the patients, when they have the screening diagnosis to the disease, pre-cancer or cancers. So we also now developed some new novel portable point-of-care treatment, such as the thermal calculation. Once was in the United States, and now we also have some devices developing in China. So this kind of approach can increase the coverage of the treatment, and then get the appropriate management of the patients that detected in the screening program. So now I think that's we for these studies we have some made some progress, and then we now also extending the benefits from the local to the region, such as for the Myanmar and Cambodia and Laos, where they are in much need of the HPV assays, and also for the corpus copy. So we developed the portable electronic corpus copy, which can be used in the low resource area settings, and also it's very easy for the training. So we, through the national key technology R&D program, we sponsored the collaborators providing the assays, HPV genotyping assays, and also the portable electronic corpus copy, provided the training. But since the pandemic, we can provide the training online. But I think they do, I think we do explore the properties screening strategies in the low resource settings. And I think for the elimination, the WHO they mentioned they made the call for the all countries, but they do need the support and involvement, the whole, not only the government but also for the whole society. So, but in the cervical cancer areas, we actually we're going through a lot of major education and communication since the past decades. So we have the National Cervical Cancer Consortium every annual meeting since 2004, because there's lots of new technologies and new knowledges that we need to share with the society. And also we need to get the public to know the cervical cancer can be prevented. So we taking the special days like the Women's Day and International HPV Awareness Day. So we made these awareness for the public, and also take the World Cancer Day to transmit this importance of cervical cancer prevention. So that's the things, I think for the education and communication play very good in the cervical cancer prevention. And then the key, we know the policy orientation is also important. For in China, for the national cervical cancer screening initiated quite late since 2009, but now they already scaling up and to expand it to the whole country. Since 2019, it's already incorporated into the National Basic Public Health Service. So this is a big achievement. Meanwhile, for the HPV vaccination, actually for us, even now, we do not we not include the HPV vaccine in the national immunization program right now, but that's what we are working hard to get there. But however, still, we have a lot of cities. They started the free HPV vaccine in their cities, sponsored by the local government, like the Harbour, Xiamen, Jinan, Chengdu, and Wuxi, and so on, and also for the Guangdong province. So even last year's very challenging pandemic areas period, they all initiate the HPV vaccination program to provide the vaccines free to the girls. I think all these innovation pilots of the cervical cancer elimination in the cities, they will strongly support the China to make strategies to really start the whole country's cervical cancer elimination. So I think that's the last part, and I want to mention how, and when the China can eliminate cervical cancer. So this is the modeling work our team have done during the past 2 years. So there's we use a dynamic prediction model in the Chinese population, and taking into account the aging in China and the urbanization, also the changes in the sexual life in the Chinese women. So and they predicted the from 2015 to the end of the century. And then we take the current strategies as the status quo, and then we see if we do not change the strategies, just to keep the current strategies only very low screening coverage, the incidence of cervical cancer in China will be predicted to increase 3 times. And then if we stop interventions, that might be 5 times. So that's the baseline, the modeling results. And then, so what kind of strategies we have to take? So that's just for the modeling, we assume from the 2021, that's this year, we introduced the HPV vaccination in the whole countries, and also increasing the screening coverage for the national world. So that we can see the cervical cancer risk will be decreased gradually. And then if you increase the budgets of the cervical cancer prevention, mainly in the vaccines and vaccination, also the screening, you will see will sharply to decrease the incidence, and then maybe go to the elimination early. We also tailored a optimal pathway. That's we taking into account the health, the costs, and also the technologies development or changing. So we assume in 2031 we could switch the HPV vaccines from bivalent to trivalent vaccine, and also we changing the screening program strategies for the vaccinated women. That will save the cost. Like we can extend the interval screening, so we'll also reduce the cost. So finally, I think we got the very good results. That's we predict we can eliminate the cervical cancer, by the end of the 2040s, or the early of the 2050s in the rural areas. But however, I thought that's the assumption means like we need to increase the screening coverage to 90% for the girls, and also increase the screening coverage at least to 70%, for the women aged 35 to 64. So that's also a lot of works, but I think this strategy showed us if we invested the health resources in the prevention. So this figure shows like in the right, this is the current health expansion. Like most of the medical resources costs in the treatment was invasive cervical cancer, and then a smaller proportion for the pre-cancer treatment, and then it's very tiny proportion for the screening program, and then it's none, in the HPV vaccination. So this is the current situation. So if you not change, we'll keep going, and then if we change the strategies, like we increase the investment for this vaccination and also the screening in early, like by the year of 5, you will see the invasive cancer, the cost in the invasive cancer treatment will be decreased, and then 15 years later, like 2035, we will see actually the cost will be saved by the implementing the HPV vaccination and screening coverage increase. So then you'll be able to save the health cost in total generally, and also you will see the decrease of the cervical cancer, and you can save 100 billion cost and avoided the cervical cancers about 7.5 million, and also the deaths. So that's I think is very inspiring results. And we also talk to share this with the key stakeholders like the government, industries. I think everybody feel very exciting for this. So I think for the cervical cancer right now is already going into the prevention and the areas, but we also do need the novel screening technologies, and also even the treatment tools to facilitate the whole cervical cancer prevention and control program. So as the last, I think that's the last question, last slide, I want to say as we hope this is cervical cancer might be the first cancer can be eliminated by the vaccination, also by the screening. So this is I think that's a historical moment, for cervical cancer, as an example for the cancer prevention history. So that's why I think I'm the researcher, and also work, very closely with the clinicians together. I think for us, we should join together to make efforts going, from the evidence to the practice, and also from the research to the policies. And finally, I think the whole world will be benefit from the joint efforts work. Thank you very much. That's the last slides. I'm happy to take questions later. Thank you.
Thank you. Thank you, Dr. Zhao, for the excellent presentation. It's about a very important topic, the prevention of cancer. And so she introducing the serious commitment from China about the elimination of cervical cancer with efficient management system and also the nationwide effort. The results are so encouraging. We keep our fingers crossed, and hopefully we will achieve this target, the first cancer elimination is cervical cancer. Thank you again. So let's move to the panel discussion for this symposium. The moderator of this section is Dr. Jiuwei from Sun Yat-sen University Cancer Center. He is the chairman of Guangzhou Young Aged Oncologist Forum and the chairman of the Guangzhou and Cancer Association of Cancer Recurrence of Metastasis Committees. And he has a long list of the designations, so he may introduce himself. And to join this panel discussion together, another professor, Professor Jihui Gao from the Henan People's Hospital, also and the other speakers, and Dr. Tuveson, and also Dr. Vokes, and also Dr. Yang. So Dr. Say, please.
Well, thanks for the invitations. It's my great honor to take part in this China-US Anti-Cancer Symposium. It's a very great honor to invite the Dr. Tuveson, and he's the chairman of the AACR, and also Dr. Vokes from the chairman of the ASCO. So so please quickly evaluate the current cooperation status in direction of the cancer clinical diagnosis and treatment between the United States and China. Maybe please, Dr. Benson. Yeah, you first.
Well, it seems to me that the clinical care in China is very sophisticated, and the lecture we received about this new CAR-T therapy, for example, for colon cancer, is very encouraging. And you know, from my perspective, the therapeutic side of things seems to be progressing extremely well in China, very admirably. And Dr. Vokes himself gave multiple examples of how nasopharyngeal carcinoma care is really pioneered by your country, the huge number of patients that you have. In the diagnostic space, we didn't spend much time on diagnostics in the last 2 hours. There is a lot of effort in this area. Most of it is early stage and laboratory based. And I think this is an area where collaboration, just like you heard from Dr. Vokes and NPC, you know, could be a part of a solution moving forward. I hope I'm addressing the general point that I think I discerned from you, but I'll turn it to Dr. Vokes and he'll have a better answer.
I don't think I do. I think I completely agree. I think that treatment is very sophisticated. It's making contributions to how we view treatment for patients worldwide. So beyond China, cisplatin gemcitabine is a standard of care in the United States too now. And you know, there's drug development that CAR T cells for solid tumors is a gigantic challenge. And to see that progress, I think is really, really encouraging. For screening, you know, the one example that going back to nasopharynx cancer, right? But maintaining or screening for EBV titers for early detection. So we've talked about HPV, this would be EBV. For nasopharynx cancer is something that's, I think, been pioneered very nicely in Hong Kong with collaborators. And that's another trial that's impressed me greatly.
Thanks.
So, you know, looking at EBV titers, and then from there, deciding who should be examined with a, you know, usually kind of uncomfortable procedure, you know, basically putting a tube into your nose and examining the nasopharynx. Although during COVID, we're all getting used to stuff being put in our noses.
Thanks. Dr. Gao? Yeah.
Thank you, Dr. Scott. I think we have not a good communication between different countries, doctors, or fundamental researchers, and I think the further we should need to do more. Not only between the doctors and doctors, but also doctors between doctors and the fundamental research. I mean, the fundamental research, I mean the medical scientist. That's all. Thank you.
Thanks. So Dr. Yang.
No, I totally agree with what has been said. I think in a China perspective, both diagnosis as well as treatment is getting harmonized with what's being practiced in the US.
Okay, so maybe compare with other diseases, development of cancer research made outstanding progress in the recent years, especially in the immunotherapy. So maybe please introduce how the United States and China should better play the role to continue to promote the development due to the different original, basic, and the development stage, clinical or basic research, and the translational research. Yeah.
Do you want us to answer in order again, Dr. Kai?
Yeah, right. Yeah.
Okay, so I'll take the basic research side of immunotherapy development, trying to understand when immunotherapies aren't working very well, trying to get to the causes of that. I mentioned local immune suppression is certainly one area that's been identified by many. And I think this is a global problem, so every patient in their tumor has a local immune suppression mechanism beyond PD-1 and CTLA-4, et cetera. Trying to combat that cooperatively, I think would make a lot of sense. I'm very impressed by your clinical trial efforts here, and I'll leave most of that conversation to Dr. Vokes, but that seems very promising. But one basic science topic that actually came up because I participated tonight is the Epstein-Barr virus. Really, I think of it as a medical oncologist as something that causes lymphoproliferative disease. But you think of it as a Chinese physician and scientist as something that causes nasopharyngeal carcinoma. Now, I'm not an expert in this area, but I took care of a few patients a few years ago who had this. I mean, what is the molecular basis of that? Same receptor, CR2, CD21. There must be something that would be fascinating to understand. And again, maybe I'm talking about something that's already in the textbooks, but that would be, I think, an interesting topic. So there's something back to you, but I'll turn it over to Dr. Vokes.
Yeah, I think that's really fascinating. The localization, of a solid tumor. It's quite similar with HPV. You have cervix cancer and you have oropharynx cancer, but not other head and neck cancer, not uterine cancer. So, what determines that local milieu that fosters the disease is unclear and only speculative. I also agree, understanding why patients progress on immunotherapy, because we celebrate immunotherapy because it really came out of nowhere, particularly for us in the solid tumor areas. We thought this was one area we never had to understand, but then it came and we had to learn all these cell names and figure out where it works and how. But many patients progress even after they initially benefit from it, and the majority really don't benefit. So I think that's a gigantic challenge moving ahead to basically learn how to even better use what's so fascinating and it's been so wonderful to see as progress goes over the last decade.
Thanks. So
we have a lot of doctors and patients. We think we should be trained and prove our research quality to a high level. Yeah.
Thanks, Dr. Yang. Yeah.
I mean, for immunotherapy, I think from a drug developer perspective, I think my view is we made a good progress in this field with the PD-1 and the PD-L1 antibodies, but we cannot stop with PD-1, PD-L1 antibodies. But the US and China, I think we have enough anti-PD-1, PD-L1 antibodies. We need to really move on to what David said, what Dr. Vokes said, really to understand how these drugs work and to figure out the new combinations. Otherwise, we'll be stuck and wasting resources doing repeated trials with PD-1, PD-L1. That's all I want to say.
Okay, yeah, and we find is we do the clinical trial, the Pacific studies, we will find that the Asian people, especially the Japanese, also is very high pneumocystis, but compared to the Caucasians. So maybe in the immunotherapies, we have to do the, I mean that maybe there is difference between the the Asia and the Caucasians. So what's your point here, Dr. Tuveson?
Well, I think we are going to find that immunotherapies work differently in different populations. I hear from a lot of colleagues that in Africa, immune therapies aren't nearly as efficacious as they are in the United States. I have to take these comments at face value. The trial designs are not as traditional as we've been seeing today. We have so much to learn actually about the immune therapies, and we will only do so with well-designed trials. I would say that each country has, and then cooperative international trials to standardize the parameters as has been done. I would say for many types of cancer with more traditional therapies. There's a single cell atlas that is being developed right now for cancer, and immune therapies is one of the reasons why it's being developed, where you get a tumor, analyze the various cells that are in the tumor and in the blood of a patient while they're being treated. So I think we just have to assume that we're going to learn different things from the different populations when they're treated with the same immunotherapies. One thing you showed me was the new therapies that Dr. Yan Li has been making, these new PD-L1 antibodies or PD-1 antibodies. Again, the affinity of the antibody actually can dictate the response characteristics clinically. And so not one PD-1 antibody is not the same as another, et cetera. And so we have to be very careful, I would say, when we look at the data. That's why it's very important to compare different therapies in the same population of patients, for example. So in any case, I'm going to leave it up to Dr. Vokes, who's been doing international clinical trials. I'm the international scientist.
Not enough. I think one big obstacle is, what's the availability of these kinds of drugs in low and middle income countries? And, if that is not solved, then not enough patients are treated, and we don't learn from their treatment. So I think where we talk about equity, this is, another reason. One is, make treatments available, but the other is that we learn when we treat diverse populations of patients. And, everything Dr. Tuveson mentioned, it is required for that we treat patients, that we collect the data, and that we collect biospecimens so we can analyze all of that. And that's where pricing of the drugs, availability, distribution of the drugs, all are important issues.
Yeah, thanks for the excellent speech. So, Dr. Vokes, you mentioned two studies which is finished in our center, and two different kind of PD-1 inhibitors in the nasopharyngeal carcinoma or NPC in China. So we compare the status. Maybe the NPC is different from the other head and neck cancers. So, but there is a characteristic that the NPC, the most of the patients have the EB virus infection. So, do you think the EB virus infections or HPV infections is a positive predictive marker for the immunotherapy? Just like HSV1, we use it for the combining the immunotherapy.
Yeah, I think it's wonderful work. You have a screening method for it, or at least one is available in theory. There is curative treatment, and the curves are quite remarkable. So it shows that when a disease is common and treatment is given in centers that have the expertise to give that treatment, then the outcomes can be very good, and they've been refined and improved over the last few years, as I showed with those trials. I think the chronotherapy may need a little bit more of investigation moving forward, but it's certainly something that's very provocative and good to see. And then you see also the limitations when the disease recurs. So we improve treatment, but we're no longer curing. And that's true for nasopharynx cancer. Usually it's true for traditional head and neck cancer, and it's certainly true for many of the other common solid tumors. And that's the challenge moving forward.
Okay, thanks. So Dr. Yan, in recent years, we have begun to see there is many innovative drugs and developed from China, leading by the Chinese company, also approved by the FDA. So at the same time, they are acquired by the traditional global large enterprise based on the United States. So what are the comments and such the innovative drugs of China original, and in the future, how should we cooperate with the United States, and we have to achieve the win-win or result in the field of the cancer research?
I think well, thank you for this question. I think it's a really good question. Dr. Vokes and us, we actually discussed that during the pre-ASCO meeting about this topic. Just a couple of things. I think China is, pumping out new innovative drugs, and some of the drugs are actually coming to the US, right? As Dr. Vokes actually discussed some of the drugs, including Eli Lilly and Innovent's collaboration of anti-PD-1 antibodies. But I think a couple of things are very important. Dr. Tsai, you also mentioned that, there are differences in terms of toxicity tolerability between the, Western population versus the Chinese population, right? So that really calls for the need for multinational, multi-center clinical trials. It will be really wonderful to enroll patients, not only just from China, but from other countries in one trial. That's the best way to really compare across different populations to see if there are actually differences in efficacy and toxicity. And just coming back to the Eli Lilly and Innovent antibody, I think FDA just, Rick Pastor just mentioned that a single country trial is going to be problematic. So I think, for China drug developers, maybe the next time design a trial, especially a pivotal trial, don't design a China-only study. Really try to increase the trial population diversity. That would be the best way to do it.
Okay, thanks, Dr. Yan. Yeah. So, Dr. Vokes and Dr. Vincent, do you have any comments on that?
Well, I will jump in. I'm not an expert on drug approval, but the idea of international collaboration, I think, is essential. And you get the diversity of populations. You can more easily accrue and more quickly accrue, and you have higher transparency and ultimately credibility in the results. The more diverse and inclusive a trial is conducted. So I would strongly support statements that trials should be international. They frequently are these days. And the only thing I would add to that is that if a drug then is approved and successful, that and some of lower and middle income countries contributed to those trials, that those drugs then are made available in those countries after the trial is completed as well, which isn't always the case.
Okay. So because of coronavirus 19, it's really hard for the Chinese doctors to take part in the ASCO or AACR. Every year we take part in the ASCO or AACR every year, but now we cannot come to the Chicago or come to the US. So in the future, do you see that which kind of ways of just like today, and we have the good example, so we communicate together. So I think that coronavirus 19 can separate us, but we can cooperate in the future. So maybe Dr. Vincent, so do you have any comments of today's topic?
Yeah, absolutely. I think as we have been discussing tonight, it's very important that we cooperate to defeat cancer. One of the earliest targeted therapy was actually development of retinoic acid by some very famous Chinese scientists, right? And that was really the first targeted therapy in my mind. And here we are in 2021, And as Dr. Vokes has said, and as we've heard today, we have made a lot of progress, but we have a lot of work to do still. And one of the ways that we can make progress is to meet together. Now, you're right, we're having a virtual format tonight, so we have people calling in from East Coast, Central Time Zone in the US, and then lots of your colleagues throughout your beautiful large country of China. And it is a different way to communicate. It's the tele-science or teleconference approach. We now have telemedicine in America because of the pandemic. The annual meeting that we have for AACR is in New Orleans in April. As of today, we think it's going to be a live meeting. Everything, of course, is being evaluated weekly. And the ASCO meeting is always, early June. And so I don't know, if our meeting will be live or not. I think it is for AACR, and I welcome any of you to come. Now, can you attend virtually? Well, there will be certain aspects of it that will be live streamed, and then the others will be available later. Will the whole thing be virtual? I think that would have to be a decision we would make if we don't have the live meeting. But again, we are committed to engaging your scientists, your physicians, in efforts to cooperate on international science cancer research projects. So thank you for bringing that up, though. And we do look forward to having this event live, next year. But, please, if you are able to come, some of you, to our annual meetings, either in AACR or ASCO, I think it helps the patients a lot. And, so thank you.
Thanks for all the, I mean that the COVID-19 can separate us, but in the cancer research, together we can make it better. So back to the chairman, Dr. Chen. Yeah.
Thank you, Dr. Chen, and also all the panelists. It's a wonderful discussion. Just feel we should have a longer time, or maybe less time. Thanks to all the audience for staying with us for the past a little bit more than 2 hours. It has been a wonderful symposium. Thanks again for all the speakers, panelists, for their presentation, and also the panel discussion to share their personal research work, and also very insightful view on lots of the major advancement recently in the novel cancer therapies. It's been, probably point out, even with the pandemic of COVID-19 virus, cancer remains one major threat for the patients all over the world. Lots of things needed to be done. So, but it should be an international work with the joint efforts across the world. Both China, US, the major countries with a large population, significant unmet medical needs. Also, very sophisticated clinical practice system, R&D, robust R&D system. A lot of advancement made from both countries. A lot of in common to share, to work together, and of course, a lot of opportunity for the synergies and due to the potential difference, as we may discuss the ethnic maybe care setting, maybe the availability problem. So looking forward in future, we continue such kind of interaction. It is wonderful. So from the basic biology to clinical development, let's bring the novel therapy to the patients global. Thank you again.
Thank you, Dr. Chen.
Thank you very much.
All right, take care. Bye-bye.
Bye, thank you.
So eChina has new partners with Oncology and provides the latest global oncology news in Chinese to doctors and professionals in China. So you can go to the website. I also wanted to forecast our next conference. Will be organized by Dr. Shen Luo from the Duke University, and also Dr. Sarah Horvitz from the University of the California, Los Angeles. Next one. So thanks for the organizer and CACA, and also USCACA, and also co-organizers, Henan Cancer Hospital, eChina here, and also the sponsor, Tianjin. If you want to watch the meeting recordings, please follow each channel. Here's a WeChat for instruction. Thanks for everyone. Now I announce the close of this conference. Thank you all. So have a good day or good evening. Bye-bye.
Okay.
Bye-bye.
All right, thank you. Bye-bye.
Bye-bye.
谢谢蔡教授。
谢谢。